To most people, a child that doesn't eat their food today but loved them yesterday might just seem like picky eating, or they won't drink their milk but just because they want their juice. And that's pretty typical in a lot of children as they're growing. But with kids with autism, we kind of see it as more of a severe problem. It's not necessarily stubbornness or ill behavior, it's actually more of a brain miscommunication, where the brain's not getting the input from the environment, and it's creating an uncomfortable and almost painful experience for eating food. And so before I kind of started my presentation and putting it together, I was kind of trying to think of a way that I could put myself in the shoes of maybe a child with autism. And not being autistic, and you guys not being autistic, it's kind of hard to understand the experience that they're having when they're presented with the food. And so this is kind of maybe far-fetched, but I thought of it as if your mom or your friend or someone put a plate of worms in front of you, you probably wouldn't jump on them, and you probably wouldn't eat them. Think about Fear Factor or some of those other shows where they're eating intestines and things that we normally don't eat on a regular basis. The texture isn't sorry, you're eating pizza. But I'm not going to go on with that. But the texture is scary to us. The texture, we know we're not going to like the texture. The taste isn't something that we're used to. And so if we put aside the notions that we know worms are something that we don't eat on a regular basis and it's not necessarily a food, and we just focus on the texture that scares us and the taste, and how that can kind of be a painful experience where you're gagging, throwing up, or whatever, and kind of thinking that that is what these kids are feeling sometimes when they see the food in front of them. So a piece of broccoli might be a pile of worms to them, if that makes sense. So I kind of had that in mind as I was putting together this presentation, just to kind of put yourself in the shoes, because I think that it's really important that you understand, or that we understand the magnitude of the uncomfortableness that they have with the foods that they're eating. So objectives. So what we're going to kind of aim to talk about during the presentation is to distinguish between picky eating and problem eating, which is kind of what I was talking about just before, where it's easy to just categorize it as picky eating, when in reality it might actually be a bigger deal. It might be problem eating, which we're going to go over the differences and some of the characteristics of the two that help us distinguish between them. Review common pediatric disorders. So in general, and with children with autism spectrum disorders. Picky eating and feeding problems are pretty common, so most of you have kids, or if you don't have kids or done babysitting, picky eating is a challenge with kids and when they start to decide what they like and they don't like. So we'll go over some of the disorders with feeding, discuss the prevalence of problem eating with autism spectrum disorders, and characteristics of actual autism spectrum disorders that influence the problem eating. So characteristics that define autistic disorders and how they affect the behaviors during feeding. We'll have an overview of repercussions of inadequate nutrient intake. So what are the repercussions of not getting the macro and micronutrients that they need, long-term and short-term. And we'll kind of see that it is more of a long-term process, and you don't see implications in growth or macronutrient deficiencies right away. It takes years almost, but it's kind of interrupting it before it actually gets to that point. We describe feeding assessments and strategies as far as looking at the child and determining what the appropriate intervention plan would be. And then review different treatment approaches with an emphasis on dietary intervention. We'll kind of touch on some behavioral approaches as far as sequential, oral sequential, sensory sequencing, and but mostly because I'm not a psychologist or a behavior analyst, I don't want to touch too much on unknown territory and say something that might not be correct. So at the end there's discussion and questions, so feel free to bring things to my attention as you observe them. But we will talk about dietary intervention and some special diets that have been studied. Not too much in depth, because I understand that you guys have kind of already talked about that or had some education on that, but we will touch base on it. And of course there's questions at the end if you have them. So a little background. Leo Kainer in 1943 first came out with the description of what we now call autism spectrum disorders, and one of his characteristics defining the disorder was feeding problems. And so So that just kind of shows that feeding problems historically linked to autism for decades, and it's kind of been a big issue. But unfortunately, research hasn't really paid so much attention to feeding disorders, and there's a couple reasons for that. There is a lot of research on autism spectrum disorders, which I'm sure you all are aware of, but the concentration is more on other core features of autism versus feeding. It doesn't really come across as a priority necessarily. And the reason for that is most likely because when we do referrals for dietitians or for nutrition consults, it's most likely based on anthropometric data. So BMIs, weight, height, so on and so forth. And so kids with autism don't necessarily have that. The growth chart isn't depleted and they aren't showing growth deficiencies, and so there's no referral made for the dietitian or for a nutrition intervention. But actually, research has shown that after the age of 8 is where you start seeing the growth, so the growth deficiencies. So if you aren't interrupting that nutrition behavior or that problem feeding behavior before the age of 8, you're not going to see a growth deficiency. It's going to be fine. Their growth is the same. And there's a study that we'll talk about too that kind of proves that theory. So the health isn't viewed as immediate risk, so we're not in any immediate rush to research that. And there's a greater need for micronutrient analysis because the vitamin C and vitamin D deficiencies are happening before the actual protein and carbohydrate deficiencies. So eating is essential to our biological survival. Obviously, we can't go days without eating. We can't go days without drinking. We lose energy. Our brains don't focus. We're tired. And it's an important role in socialization. If we think about all the things we do around eating, whether it's getting together with family, a lunch and learn like this, you're eating pizza, it's social, you learn independent skills to feed yourself. There's a lot of aspects, and some people don't always think, I guess, about how much eating impacts socialization and survival. So in order, I think, to understand the developmental delayed feeding, I think we have to understand the normal development of feeding. And so there's a window, the first 3 years of life, where automatically most neurotypical children develop their feeding skills. And so we're just going to quick go over kind of that process in general of your typical developmental children. So the first 3 years, by the first 4 to 6 months, you'll kind of start seeing the semi-solids added, so baby food, cereals, pureed foods. By 8 months, they begin to show an interest in their feeding themselves, so reaching for the spoon, bringing it to their mouth, trying, and it spills, but they're showing interest. By 12 to 24 months, they begin to eat the same foods as the rest of the family, and they begin to develop food preferences. So you'll notice they aren't eating the peas, or they aren't eating the meats. And by 18 months, the toddlers learn to feed themselves with a spoon. So we're seeing that independence and that socialization. By 24 months, they're beginning those social skills where they can communicate with the feeder, the caregiver, and they're interacting as far as telling them what they like and what they don't like and feeding themselves. So that's a pretty natural progression as far as feeding skills go. So there was a study done by the University of Bristol in 2010 where they investigated the feeding, diet, and growth of young children with ASD. And what they did is they had parents fill out feeding questionnaires, food frequency questionnaires, at the ages of 16, 15, 24, 38, and 54 months. A food variety score was created, which I'll give you an example in the next slide, but basically just based on what foods they eat and how often per week is how they calculate that variety score. And then the content of the diet was calculated at 38 months. The feeding and dietary patterns of 79 children with ASD were compared to almost 12,000 control. So this is kind of an example of a food variety of how they would do that. So a typical diet, kind of bland, the wheat cereal, milk, orange juice, white bread, toasted cheese and tomato, meat and 2 vegetables. So they're eating only about 11 foods there with that meal. And then this says suggestion for increasing variety, but most kids are not going to eat these foods. But this is just an example of a diet with quite a bit more foods. This would be 34 foods different. And so typically 20 to 30 different foods a week is generally considered a good variety. So if the food frequency tells us that less than 30 or greater than 30 foods are being eaten, that's very good. Like 25 to 30 is good. Less than 20 is poor, and less than 10 is very poor. So this 11 foods is pretty poor. So the results found that they showed late intro to solids after 6 months. So if you're from the previous slide, about 4 to 6 months is when we're introducing regular solids. So even after 6 months, they're still having trouble introducing the solids, and they're categorized as slow feeders. About 15 to 24 months, the children with autism were finding difficult to feed, and from 15 months, the autism group had a less varied diet than the controls. So if you remember, in regular development, around 12 to 24 months is where they're kind of exploring their food options and giving their food preferences. And so even at 15 months, they're still not as varied as the controls. And by 54 months, 8% of the autism children were taking special diets for allergies. They consumed less vegetables, salad, and fresh fruit, but actually also less sweets and fizzy drinks, and most likely due to food selectivity and texture and stuff and things like that. At 38 months, intakes of energy, fat, carb, and protein were actually similar, which are those macronutrients that I was kind of talking about before, where we don't really see those deplete much initially, but we do see those micronutrients like vitamin C, D, and A start to deplete. And that's where we kind of want to catch it before it turns into something bigger. There wasn't any apparent differences in weight, height, or BMI either. And that's, again, what we talked about, why there's kind of less research, is because you don't see that difference in growth right away. So in conclusion, they had less varied diet by 15 months. They were slow eaters, but the energy intake was not currently impaired. So the prevalence of feeding problems in ASD. Not a lot of research, but the research that they have is mostly done by questionnaires by parents and caregivers. So parents and caregivers are given surveys and questionnaires, and this is kind of what some research has come up with. One study said that more than 60% of parents describe children to have strong food preferences. And of those 60%, only 6.7% of those parents describe them as feeding problems. So this kind of shows that they see the strong preferences, but it's not really recognized as a problem because their child is still growing and they haven't really seen major implications of that. Another study said 67% of parents describe children as picky eaters, and that's just kind of compared to show that the research is pretty similar and the findings are pretty similar. 67% to 60% isn't much of a difference, and there's actually a more recent study that I didn't put on here that I found like last minute that said 74%. So increasing, but still pretty stable, or at the same percentage. Those with ASD ate more restricted range of foods and had higher rates of food refusal than their neurotypical peers, which is common and we've kind of touched base on already. The general agreement from the research was that the nature of the disorders was food selectivity by type. And to define food selectivity by type is basically just a narrow range of foods that the child picks. So avoiding specific food groups as a whole, and only eating few foods. So whether there's only 3 foods that they'll eat: white bread, applesauce, and carrots. Just random foods that they'll eat, just very few. Conditions like dysphagia, drooling, chewing, and oral motor difficulties are not necessarily reported in specific autism literature, but more prevalent in those who have autism and other medical conditions on top of that. So the scope of our discussion, kind of based off this research, is looking at physiological and behavioral basis of food selectivity versus drooling, chewing, oral motor difficulties in association with food behaviors. So this is where we kind of get into picky versus problem eating. So characteristics of both that kind of help us differentiate whether you have a picky eater or an actual problem that you might want to get assessment for. So picky eating would be eating less than 30 foods. Problem eating less than 20 foods. And that's something that you would use your food frequency to determine. Eats at least 1 food in each food group and eats fewer foods over time. For the problem eating, tolerates new food on the plate, And for problem eaters, you see that need for sameness, not accepting new foods. Even if you, generally, if you 10 exposures, a child will try the food. And that you'll see that with picky eaters, they'll be stubborn and they'll refuse it for about 10 times. But the problem eaters are unwilling to try those foods after 10 times. Categories of feeding problems. Pica, which I'm sure you're all familiar with, so eating non-nutritional foods, whether it's soap, paper, cloth, metal, plastic. Obviously dangerous, it can cause GI obstructions, which can cause a whole bunch of other medical problems. And actually, it's pretty common in children, autistic or not. Rumination, which is the constant regurgitation of food, so bringing food from the stomach back up. Sorry for those that are still eating pizza. But bringing the food back up to the throat and then swallowing it back down repeatedly, which can cause irritation to the esophagus and deterioration almost, causing pain. And so imagine trying to swallow a big piece of bread or meat and then your esophagus is like raw inside. It's painful, and that could cause behavioral issues towards those certain foods. Food selectivity and food refusal. So we're looking at texture, type, presentation, as far as selectivity goes, and then refusal, partial and total food refusal, as far as food groups is mostly what we're talking about there. Refusing to eat fruits and vegetables is pretty common, even for ourselves. Skill deficit, so that goes kind of back into chewing, tongue lateralization, and some other medical issues. But food selectivity and food refusal are kind of what we're going to focus on, because that's the most common research finds in children with autism. So factors affecting feeding problems, medical issues, metabolic abnormalities, so some might have diabetes, we have blood sugar, insulin abnormalities, GI issues, anatomical defects, oral motor deficits, and hypersensitivity, and also hyposensitivity would be up there too. And those are all feeding behaviors could all be secondary to all those medical issues. And we'll kind of talk about how it's a multifactorial approach when doing assessments and treatments, and that's because sometimes when you can solve those medical issues, you can solve a lot of behavioral problems. And the communication, common autistic children have communication barriers, and so when the communication's not there, they can't tell you that they're having stomach problems or that milk makes them feel sick. And different GI issues are pretty common, that's why I'm picking on those. But so sometimes resolving those can help with behavior as well. Developmental issues, so this kind of encompasses autism as well. 33 to 80% of children with developmental issues have some sort of feeding problem. Environmental issues, so disruptive family functioning, lack of structure, reinforcements, if you're being positively reinforced for negative behavior, the family fights all the time, or mealtime stressful, that can cause behavior problems. Selected ASD characteristics that affect the feeding. Impaired communication and social interaction, so not being able to communicate with your caregiver or the feeder that's feeding you to tell them that, you know, maybe it's hard for you to chew, or maybe it's painful to eat this, or this makes you feel sick. Restricted interest in activities, so only, having specific interests as far as maybe, I guess what I want to say is a way to help with this issue would be feeding while they're doing interests that they like. So if they like playing with a certain toy, letting them play with that toy while they're eating to kind of create that connection, positive connection. They like the sameness, ritualism, so that goes into eating the same foods over and over and not liking to try new ones. Sensory hyper and hyposensitivity, whether it's to light, flavor. So if you have a child that is sensitive to certain types of flavors, if you're making beans, rice, and chicken for dinner, maybe taking out a serving of beans and rice before flavoring it or spicing it up so that they can try it. Maybe it's the spice, maybe it's the flavor that you're putting on the beans and the rice that's causing the behavioral feeding problems. And then gastrointestinal problems. I have a question mark there just because there actually is increasing research on the prevalence of GI problems with autism, and that it's actually, they're finding it's pretty common that children with autism have GI problems. Common preferences, children with autism for dry, crunchy foods. So if they, okay, so say they like dry, crunchy foods and you have cooked carrots for dinner, and they're not eating the cooked carrots, but what if you gave them cold carrots? They might eat them because they like that crunching. Refusal of soft, smooth textures. Steaming broccoli. Some people steam broccoli really soft, so instead of steaming the broccoli soft and mushy, steaming it only till it's hot and then it's still crunchy, and maybe they'll be more apt to eat that as well. Kids with autism tend to have strong preference for carbohydrate foods and dislike those fruits and vegetables. And actually, it's not really uncommon for most people to have a strong urge for carbohydrate foods. I mean, I myself would consider myself a carboholic sometimes. And we like the breads, it's comfort food. It reduces, or it releases chemicals in our brain that makes us feel good. And so that's really not necessarily specific to just autism, but to kids and to people in general. Preference of finger foods, they like to have control of the situation, so being able to grab the food themselves and touch it is a preference of theirs. Preference of certain brands or preparation methods, maybe they don't like baked chicken, but they like fried chicken. Not ideal, but as far as preparation methods go and brands, some of us are even picky about brands. I know that I'm picky about certain foods and their brands as well. And then preference of food of particular colors. Maybe they only eat green foods. Maybe they only eat yellow foods, or gray food, or like the off-white foods, like white cauliflower, mashed potatoes, baked potatoes. Challenging meal behaviors that you probably see. With food refusal, you'll see crying, screaming, turning away from food, throwing food, spitting food. Pretty stressful situation. No one likes to see their kids upset. No one likes to deal with kids that are upset, especially to that level. And so it can cause a lot of stress during the feeding time. Food selectivity, refuses to try new foods, refuses categories of foods, whole food groups. Food jags, which is defined, I don't know if you've heard of the term before, but changing in eating habits. So they'll start by eating all the foods on their plate, and then over time they start only eating one food and they'll leave the rest. So if you have a fruit, vegetable, a protein, and a grain, and they're only eating the grain, that would be a food jag. But they used to eat all the foods, that would be defined as a food jag. Repercussions of problem eating. So we have caregiver frustrations, mealtime chaos, stressful environment, limited flexibility, eating out, vacation, school. I'm a server at brands as well, and nights and weekends. And a couple months ago, before I even knew I was doing this, I had a family come in, and I was getting ready to take their drink orders, and I started with the young girl in the back, and I was asking her what she wanted to drink, and she wasn't making eye contact. She wasn't even acknowledging that I was talking to her. And then her mom tapped me on the shoulder and said that she's autistic, and she's not going to need anything. We have everything for her. So I went on with the meal, brought them their food, and sure enough, she had a lunch pail with all these certain foods cut up in a certain way, the way she wants them, with a juice, and she just was happy, ate her food, didn't really pay attention to what was going on around her. And so at the end, I had asked the mom, I explained to her where I work and why I was kind of interested in it, and she explained the same thing, that she's very ritualistic. She eats the same things for every meal. She has to have her sandwich cut up actually into strips versus triangles or squares, and so I thought that was really interesting. And so when I put this in here, I wanted to mention that because it is definitely limits you as far as going out with the family, going on vacation, and even starting in school. Social development, again, eating is, in that first 3 years, you're developing these social skills. You're communicating with the caregiver that's feeding you, you're communicating with the family at the table, and letting people know what you like and dislike. So there's an impairment in that. High intake of multivitamin and multimineral nutrient supplements. And supplements, I don't want to knock supplements, but we like to encourage that you're getting your nutrients from actual foods. And so we want to prevent dependence on supplements. And so when we start seeing a high intake of these supplements, of either multivitamins or single nutrients, sometimes it's easy for that to become a simple solution, and that's not necessarily where we want to lead the treatment to be. So that is considered a repercussion just because it's not an ideal situation that we want to be. And also, sometimes when you're taking too many supplements, you can have toxicities and other and then the nutrients interplay with different nutrients and cause deficiencies in other areas. And then, of course, inadequate nutrient intake of micro and macronutrient deficiencies, which we're going to kind of talk about here in the next few slides. So, eating that number of narrow foods that's pretty typical of autistic children, we're limiting calorie intake, restricting micro and macronutrient intake. Fruits and vegetables seem to be lacking. However, the growth seems adequate, which we kind of touched base on as well. But we continue to monitor the growth chart to watch for any declines in growth. And immediately once we see that, then it's definitely time to take intervention. So inadequate carbohydrate intake. So your macronutrients are going to be carbohydrates, fat, and protein. And so once we start seeing a deficiency in these macronutrients, we have a real problem. So if you start seeing carbohydrate intake decline, you can get a ketone buildup. And those ketones are acids in the blood that form when fat seizes energy. So if your body's not getting enough carbohydrates, it starts taking from the fat stores of your body and sending ketones through your blood, which accumulates acidic ketones, and it's found in your urine, is how they find out if you have increased ketones. And so dangerously high levels can get in the bloodstream, and they risk electrolyte imbalance, dehydration, fatigue, and digestive disturbances. And so even just this digestive disturbances isn't going back to that medical issue where that could be influencing the behavior. So if you're having a carbohydrate deficiency and that's causing digestive disturbances, fixing that problem can help fix the behaviors of the feeding. And electrolyte imbalances is a dangerous thing to mess around with as well. Protein deficiencies. So protein's in every tissue of the body, and so when you lack protein, physical changes. So your hair changes, your nails change, your tissues, your skin changes, and as it gets more severe, the tissues around your organs change, and muscle mass decreases. And so this little guy up here, he's an example of a disease that is a result of protein deficiency called kwashiorkor. I'm never really exactly sure how to pronounce it, but I think that's a good guess. And that can cause enlarged protruding abdomen, which is that guy up there, and it's just fluid retention. So that can happen in the abdomen, happens in the face, like the little baby at the bottom, in your arms, your legs. And not only is it uncomfortable and painful, but it also causes an imbalance in sodium in the body, and it goes back to that electrolyte imbalance as well. Fat deficiency. So everyone thinks that fat is really bad. No one wants to eat fat. We're trying to watch our fat intake. But actually, fat is actually good in small doses. And we want to encourage fat in the diet because it has a lot to do with vitamins, fat-soluble vitamins. So vitamin D is an example of that, vitamin E. And it helps with the absorption of those and other antioxidants. And also the brain uses fat for functioning. And so omega-3 fatty acids are actually becoming really popular, especially in the mental health field. Not just autism, but schizophrenia, bipolar. And I know that the psychiatrist, Dr. Brubaker, he prescribes fish oils a lot. And I think that it probably has a lot to do with this theory that it can improve mood, it can improve concentration and learning. Those fatty acids are good for brain development and functioning. And so then, of course, other than the macronutrients, you have micronutrient deficiencies. And the consequences can be severe and almost sometimes irreversible. And this is I don't know how well you can see it, but this is an example of scurvy, and the gums are really irritated and red and puffy. That's a vitamin C deficiency. This is a boy with rickets, and rickets is a vitamin D deficiency, and vitamin D helps control the calcium and phosphate levels in your body. And so when vitamin D is deficient, it's taking calcium and phosphate from your bones, causing them to be very limber and weak. And so obviously you can see that's probably really painful. Blurred vision, vitamin A deficiency. Vitamin A is really big with your vision, and it can cause blurred vision or night blindness even. So these are all things we want to avoid by assessing these problem eating behaviors and fixing them as soon as we can. And so this is the My Plate. And so I gave you guys a note card and a pen when I first started. And this is how I kind of put it in perspective for people sometimes. The pens are new, so they might have a rubber thing on the bottom. So we have 5 food groups. We have 5 fingers, right? grains, protein, fruits, vegetable, and dairy. So go ahead, take your pen, and then write your name on the piece of paper. Okay, so it was pretty easy, right? We do it all the time. We write our name with our fingers. Now if you can set the pen down and then tuck your thumb in. Now try to pick up the pen with your 4 fingers and then write your name again. With just your 4 fingers without using your thumb. A little more difficult, right? Okay, so then we're going to set our pens down one more time and then tuck your pointer finger in with your thumb finger and then try to pick up the pen with 3 fingers and write your name. Obviously it gets more difficult each time. So when we're writing with all 5 fingers, just like your body when it's running on all 5 food groups, it's functioning just fine. It's functioning like it should. But when you take away food groups, like kids with feeding problems do, they tend to avoid whole food groups. You take away those fingers, it's a lot harder to write down your name. It's a lot harder to pick up the pen and fix it so that it works. So it's kind of a way to put into perspective your body functioning on food groups that it's missing and nutrients that it's missing. It's difficult. It needs the 5 food groups, just like you need the 5 fingers to write legible. Feeding assessment strategies. So ideally we aim to capture the following when we're doing assessments. We want to look at general feeding concerns, mealtime difficulties, especially unique to the autistic child in the population. So we're looking at selectivity, ritualistic behavior, emotional responses to non-preferred foods, and then we're looking at the relationship between selective habits and the possible nutrition inadequacies that come with those selective behaviors. Some possible assessments would be questionnaires. So standardized questionnaires, there's about 4 of them. One is used most commonly, and we'll review those briefly. Estimate the nutrient intake that they're getting, so we'll use different approaches to take those. Intakes, structured mealtime behavior observations, and we'll look at more objective data with that. So 4 questionnaires that can be used. Behavioral pediatric feeding assessment scale, children's eating behavioral inventory, screening tool of feeding problems, and brief autism mealtime inventory. The most popular use is children's eating behavioral inventory, and it's not necessarily specific to autism, but to other developmental disabilities as well. The only one really that's specific is the brief autism mealtime behavioral inventory, and that's specific to autism, but the behavioral pediatric feeding and the screening tool are mostly focused on general population of feeding problems. The first one is a 35-item measure, so 35 questions, and it's developed to measure the mealtime behavior problems typically developing children in the general population. The step is a 23-item measure intended feeding problems with individual developmental issues, and the categories that they're looking at there are aspiration risk, selectivity, feeding skills, food refusal related to behavior problems, so spitting food out, throwing food, nutrition-related behavioral problems, look at pica in that section as well. The one that's most used is the children one. The CEBI, I can't remember it off the top of my head right now. It's a 40-item measure intended to assess eating and mealtime problems with children with medical and developmental issues. And so here's an example of kind of a questionnaire. You probably can't read it from way back there, but basically it's a scale from 1 to 6, 1 being very well, and 6 being not at all like a normal child. And so the first question is, to what extent was the child's behavioral towards peers like that of a normal child today? Or this one says, how well did this child get along with you and take notice of you today? And so, although they're not these specific examples of questions are not necessarily geared with food-specific questions, eventually, within the 40 questions, they get to food specifics. And the Bambi is an 18-item scale designed to evaluate the feeding problems associated with ASD. And we're looking at 3 characteristics. our categories: limited variety, food refusal, and features of autism, which are all kind of things that we touched on earlier, as are pretty common, is that limited variety, ritualism, food refusal, so refusing food groups, and then the features of autism that impact the behaviors. And this is kind of an example of what a questionnaire might look like. So my child counts during mealtime, 1 being never, 5 being almost every meal, and then yes or no if the parent thinks it's a problem or not. And so if you remember back to like the first study that I showed you, when 60% of kids with disabilities had feeding problems, but only 6.7% of the parents actually thought it was a problem. That's where kind of that yes and no factor comes in, and that's how we get that data. Pros and cons of standardized assessments. They're a quick access to information. You get an actual score, and it can yield important data regarding the parent's perception of the problem, which is sometimes difficult to do just by watching behaviors. Cons would be no real link to behavioral data, and there's no necessarily cutoff score as far as, with the food variety, we said 30 foods or more is good, and less than 20 is poor. When we're looking at estimates of nutrient intake, there's 2 general categories that we use. We identify specific foods and quantities by performing 24-hour recall or a food diary. A 24-hour recall is pretty common. I use them when I do one-on-one consults with consumers in residential and in the community. And so basically you sit down and within a 24-hour period of time, obviously ask what they ate and how much, if there was jelly on their toast, butter on their toast, cream or coffee in their sugar. Because a lot of times they'll say, yeah, I had coffee, toast, and a banana for breakfast, but then you find out that they actually had 2 pieces of toast, 3 cups of coffee, and like a quarter cup of jelly on their toast or something. So it's important that we get those quantities. Food diary is more of an expanded period of time. So for instance, before I meet with someone, I might call them and say, could you record 3 days of what you eat, as accurate as you can? How much you eat, how much you ate in, maybe how you feel after you eat those certain foods, how much of those foods you ate, and the time that you ate them. And then we look at food frequency, and this is where we get a list of foods and how often you're eating the foods. This will help us understand if they're getting that nutrient intake that they need, if they're getting that variety of foods. So we do a food frequency questionnaire, and there's all different kinds of food frequency questionnaires. They develop them all the time, and they're very different. But basically, it's usually a scale of 1 to 10, sometimes multiple choice, and you say, how often do you eat meats? Once a week, twice a week, 3 to 4 times a week, 1 to 2 times a year, or never. And so questions like that for every food and every food group, and there are various lengths. Pros and cons to the diary and recall: flexibility of the analysis, it's unlimited specificity of food type. Cons would be the demand is placed on the respondent, so the information you're getting is from the actual client or caregiver. Sometimes it's not good for long-term dietary habits, and a need for a trained dietary interviewer could be necessary as well. Food frequency, inventory, pros and cons. A pro would be general assessment of intake patterns, easy to administer, it's less time consuming. Cons would be it sacrifices the collection of more precise dietary information. So it's very general, it's an estimation, it's not a specific count. Behavioral observation. When you're doing behavioral observation, key considerations to look at would be the environment, the feeder, the caregiver, their attitude, their response to refusal, how they're dealing with it. Foods, the types of foods they're eating, maybe certain textures that you're noticing that they're leaning towards. Presentation, maybe you notice that they do better when you do 1 food at a time or 2 foods on the plate at a time. Bolus size, overwhelming bites, if they do better with small bites. It's something to pay attention to. Pros and cons is that it gives you some objective data, which is always important. We love objective data regarding the actual behaviors. Cons would be cost, time, data collection, emotional response to the behaviors. So levels of intervention. First we start out with the caregiver, parent education, where we would go over multiple disciplines, guidance, recommendations, and provide them with educational handouts. And if that for some reason isn't working, we look at outpatient therapy. behavioral psychology, nutrition, oral motor therapy. During my internship, I did a rotation at Mary Free Bed, and I worked with a dietitian that works in the feeding clinic there, and she worked with a speech pathologist and a nurse and a behavior analyst, and they all worked together, outpatient therapy for mostly infants and kids. And then intensive feeding programs, so that could be inpatient, day treatment, multidisciplinary, so you have that interdisciplinary team. And that's more intense when you're seeing real lack of growth and something intense is done and nothing else is working. Developing a plan, so we're going to look at baseline data collection, what's tolerated, and break down the task into many steps. As with anything, having realistic goals set increases success. So starting out with mini steps where, for instance, in weight loss, we would set a goal of 5 pounds versus 50 pounds because you're going to lose 5 pounds before you lose 50. And the long time that it takes to lose 50 pounds, you're going to lose interest. And so that's kind of what we're talking about with mini steps there is setting goals that they can accomplish, that you can reward, to keep them motivated. Addressing anything that can make the experience aversive. So seating, medications, oral motor skills, and that's kind of where we talk about that multifactorial influence on the behaviors again. Identifying highly preferred reinforcers. Reinforcers should be varied and rotated randomly. Used as a reward, but weaned over time, and just to help maintain the child's interest. Kids will do a lot of things for things that they love. So, treatment designed on an individual level, so it's important to understand that not all autistic children, there's not a typical autistic child, just like there's not a typical brown-haired child. Everyone's different, and so it's important to tailor the treatment to the specific child's needs. Using demand fading, understanding it's multifactorial again, so that's those behavioral issues during feeding that could be secondary to other medical issues. If you're chewing a piece of meat and you can't move your tongue to put it to the back of your throat, you're not going to want to chew the meat because it's scary because you feel like you're going to choke. So fixing that tongue malfunction could help better their behavior with the meat, and that might be the only reason that they're refusing the meat. Treatment approaches, medical treatments. There's no real medical treatments pertaining to the autism behavioral aspect specifically, but things like anti-reflux medications, if they're experiencing GERD, which is pretty common, can help with the pain. And again, if you fix that pain with the GERD, that could cure behaviors. Motility and appetite stimulants. Reglan it empties the stomach more frequently, and so it actually acts as an appetite stimulant as well as a motility agent. And periactin, which is actually used to treat allergies, but it can also be used as an appetite stimulant as well. Usually, we don't want to go straight to appetite stimulant. We want to try to encourage them to eat without that. But again, if it becomes severe enough, that might be something that needs to be looked into. Occupational interventions, sensory, food play, food chaining, behavioral interventions, and occupational interventions. So sensory integration, multiple sensory domains, not necessarily food being the focus. Sometimes not necessarily the food, it's the texture and the feeling on the lips, which is similar to systematic desensitization. So it's kind of the same mechanism, but just but you're using food versus other things than food. Sequential oral sensory, small gradual changes, child sets the pace. So an example of sequential oral sensory with food, child lets the carrots on the plate, then he will touch the carrots, he'll bring the carrots to the lips, he might lick the carrots before he actually eats the carrots. I would imagine, I've never had to try to cure a phobia, but similar to that, where you would want to expose them to the food in this case without those painful stimuli or the fears that they're feeling as they're eating them. Food chaining, starting with something that the child accepts. So during that assessment or behavioral observation, you could see what kind of foods that they tend to eat most or what they go towards. And then small gradual changes. So they eat lots of French fries. Eventually you could cut up apples into long thin sticks that look like French fries, and they might eat the apples that way versus if they were in slices or a whole apple. And then you could try it with pears. And maybe, like the girl that was at Brand's, maybe eating a sandwich in sticks like that is for that reason, I don't know, but the way they're cut might be for a reason similar to this. And then dietary interventions. The three kind of aspects of dietary interventions that are important for success would be the caregiver's behavior, eating strategies, and then nutrition therapies. So caregiver associated with parent behaviors associated with increasing variety of foods that the child eats, so offering different foods, scheduling regular meal times, snack times, sitting down as a family at specific times. At 5 o'clock we always eat to keep that ritualistic behavior. Not preparing alternative meals, so only having the one meal that the family's eating, and trying to help them learn that that they have to eat what everyone else is eating as much as possible. But preparing them, as I said, like doing the rice and the beans where you don't flavor them, that would not necessarily be an alternative meal. It would just be another way of preparing the food. Encouraging daily intake of fruits and vegetables, and the parents eating a variety of foods. What they see, they might act as their parents do. So watching their parents eat different foods might be something that helps them try the new foods. Eating strategies. Avoid overwhelming a child, so avoid putting too much on a plate. Think about a Thanksgiving dinner on a little dessert plate. It's overwhelming for you and I. And so I think that's kind of how they would see too much food on too much plate. On a plate would be overwhelming to them, and they're not going to be willing to try that. It's scary. Introduce foods in the forms that's similar to the child eats already, so kind of like that food chaining thing we just talked about. Make small, gradual changes, the mini steps, and then expect slow changes as well. And nutrition therapies. So there's no real evidence based that nutrition therapies or special therapeutic diets actually link specifically to autism behaviors. But again, it goes back to that, curing allergies in medical conditions. So if you have Crohn's disease or a GI issue, or gluten allergy or something, fixing that with the diet might help them eat other foods. And then just being aware of toxicities and deficiencies with special diets. Supplements to consider, B6, and antioxidants, so vitamin C, vitamin A, that help fight off those free radicals that might be lacking if they're not eating the fruits and vegetables. Zinc is actually interesting. Deficiency in zinc, the RDA doesn't require a lot of zinc, and like 6 months to 3 years is only 3 milligrams a day, and like 9 to 13 is only 8 milligrams a day, so you don't need a high amount every day, but actually a deficiency can cause a lot of problems. Zinc's actually really important in the body, and interesting that I read in one of the studies was that a deficiency in zinc has an effect on your taste. So kids who might be experiencing a zinc deficiency might be tasting foods differently, or foods might be tasting differently to them where they don't like them because of that deficiency. So supplementing the zinc and fixing that deficiency could help behaviors to certain foods. And then vitamin B12, coming from a lot of meat sources and animal sources, is important as well. So therapeutic diets help with GI issues, that hypothesis of leaky gut, if you've heard of leaky gut, so the contents of your intestines leaking into the bloodstream and causing digestive problems. Food allergies and sensitivities would be another reason why. And then just again, diet and behavior is debated. It's been long debated, and it'll probably continue to be debated for a while. But hopefully they'll come out with more research on that. So just some basic diets that you might try is the gluten-free, casein-free diet, so dairy products, gluten diet, or removing gluten. The Feingold diet eliminates additives and chemicals, artificial flavors, colors, etc. Specific carbohydrate diet, so that would be eliminating, simple sugars, lactose, sucrose, different white breads and grains like that. Yeast-free diet, so yeast and sugars, eliminating that. I'm sure you're most familiar with the gluten-free, casein-free diet, because that's been researched the most as far as its effects on feeding problem behaviors. So that diet, we just encourage more fruits and vegetables and less bread and more meat and protein. There is a risk with the gluten-free or the iron, zinc, B vitamins, and folate deficiencies, so that might be where a supplement could come in handy there. And then dairy-free diet, we're looking at calcium, vitamin D, and vitamin D, B12, and protein deficiencies. Some other supplements to consider probiotics just to help with beneficial gut, effect on the gut. So those live microorganisms. There's no real link between the two, but it's just a theory that it might help with digestive problems or GI issues. And then back to that omega-3 fatty acids. Inhibits the body's inflammatory response, helps reduce asthma, heart disease, some arthritis, and it's important in the brain development. And so there's a theory that maybe getting essential omega-3s helps with development in the brain as well. And you can find omega-3s in fatty fish, walnuts, flax seeds, canola, and flaxseed oils. And so basically, to conclude, unfortunately there's not a lot of research linking the two, but hopefully that the awareness of nutrition implications and growth defects will become more apparent and research will become more evident. And understanding that's multifactorial, so again, going back to that, fixing other problems that might contribute to the behavior. So not necessarily, feeding problems might not necessarily just be because they're autistic, it might be other factors to do with that. Kind of trying to encourage people to see that problem eating it can be more severe than picky eating. So understanding the difference between the two, and if you see a problem eating, finding assessment for that as soon as you can. Individualizing the therapies and interventions is important, as everybody is different and everyone has different symptoms. And then tracking data is the most objective way that you possibly can to help with assessments and interventions. So, my references, and then